So then we're moving on in the agenda so far in time, and we are going to have a very quick introduction at the moment to set the context, so that we can let you know where this collaboration is coming from, what was the beginning of this journey that we started a few years ago, and the motivation for bringing these groups together. So then I will pass on to Professor Wally Wang, that will provide some introductory words about the symposium and its origins. Would you like to share some slides, Wally?
No, there's no slide for my introduction. Okay. Thank you, Maria, for your effort to organize this symposium. Although it's virtual, but it's just like we communicate in person. So also many thanks for Professor Bonner to give us a very warm welcome remarks. It highlights what we have achieved in the past years. So I think that today is our great pleasure to work together to share our research progress between your groups and your group and my group. I think that today we have, although we only have very limited time to share our research progress, but it will highlight a new start for our future collaboration. So I think that most of our achievements in the past 6 years will be demonstrated in the coming presentations. So I'm going to save more time for our presentation. This is my brief introduction, and also I look forward to further collaboration with the participants today, and also hope that we can have more audience that would work together with us to promote the global network on cognitive assessment across different cultures. Thank you very much, Maria.
Thank you very much, Professor Wally, for these kind words. I will use some slides for the introduction because I like photos, so I would like to share some images that illustrate the beginning of the journey, if that's okay. Can you see my slides?
Yes.
So then I should probably mention that I met Professor Wally Want as part of an initiative that she was leading with some colleagues in the United Kingdom via some funding they secured through a grant, and they put together a very ambitious and timely initiative that was called the Global Dementia Prevention Program. And that program aim to bring together multidisciplinary and multi-sectoral efforts to address some of the key challenges posed by dementia. You see that pretty much the same conversation that we're going to have today. So these efforts have been kept, and we have been continue working since we joined our groups expertise via this initiative led by Professor Wang. Started, I think, in 2018. So we wanted to create a global network of researchers with expertise in clinical science, technologies, artificial intelligence, digital technologies, neuroscience, data, etc., so that we could adopt a holistic approach to the dementia challenge, because we know that that challenge that has been declared a global challenge have different faces, different presentation, different kind of ingredients in different countries. So we wanted to come together to explore how much of those potential sources or aspects that make up those challenges were shared across countries, and we had a number of developed and developing countries. And as a result of that initiative, we published this paper tackling dementia globally, the Global Dementia Prevention Program, which is available. And as I said, these videos will be shared later on. So then we, via this collaboration, a group of us managed to go to China, to Peking, and we visited Professor Wang, and we have a wonderful symposium, probably as much more ambitious than this one. We were there for a couple of days, and we had the opportunity to discuss a very ambitious agenda that started some of the work that we are going to be sharing here today. Okay, so then the motivations, the key motivations for this conversation that we started in Peking in 2018 were our shared interest to identify culture-free assessments, assessment that we could use in populations with different background, different languages, different socio-cultural and socioeconomic status. So then we were really interested in bringing. Sorry, I'm still managing. In bringing the community, our groups together to discuss this various initiative. So we also wanted to overcome problems. For example, we were interested in longitudinal studies. We wanted to develop tools that could be used for repeated assessment. We also wanted to develop affordable solution. One of the key challenges our societies face, especially in developing countries between the South and the North, that this is a conversation that we will be addressing today, is just access to these state-of-the-art technologies, state-of-the-art biomarker, novel assessments. So we wanted to explore potential strategies to make this development more accessible, but at the same time, reliable and validated. And we also wanted to make sure that this development were more valid in terms of psychometric validity, their reliability, and so on and so forth. I think these were the core themes. Am I right, Wally? I think these were the core themes that we discussed at that particular symposium. And as you will see, these are potentially, hopefully, the core themes that we will continue discussing in this conversation today via the two groups. Okay, so I will stop now and I will then pass on the baton to Professor Wally Wang so that she can introduce the speakers from her group.
Okay, thank you, Maria, for giving us such wonderful review of what we have achieved in past years, starting from our first meeting in 2018. So it's 6 years. Although we have not met in person for a couple of years, but I think that we have always kept in frequent contact because cognitive assessment is very important in the field of dementia prevention, especially for people coming from different cultures and different regions in the world. So thank you very much. And also now it's my time to introduce my team. Thank you, Maria, for putting us in the first session. Today, from my group, we have arranged 6 speakers. Each speaker will have 10 minutes to give a brief overview of what we are doing in different aspects of cognitive assessment. Our speakers include Professor Zhang Ming from San Yat-sen University, the third affiliate hospital, Professor Fengchen Zhang from Beijing Post and Communication University, Dr. Luchun Wang from Beijing Anding Hospital. She was a graduate from my team. And our PhD candidate, Zhang Mang, he's currently still working on his graduate thesis. And also Dr. Haifeng Zhang. Haifeng is currently the physician in our hospital. He visited the Edinburgh University in 2018. So today we will meet so many friends and we will get to know so many new friends. So, so I'm going to kick off the presentation from my team. I'm going to share my slides here. Yes.
Yeah, we can see your slides very well.
Right. Yeah. So thank you very much. So today I'm going to share some of our work on the cognitive screening instrument, including validation and creating nationwide norms. Yeah, in China, we have seen a huge number of persons living with dementia. And this number will increase in the next couple of decades because the number of people, the old adults will increase dramatically in the coming decades. We have already expected that. So to minimize the impact of dementia on the social and the medical care, last year, the National Health Commission has kicked off the National Action Plan for promoting dementia care and prevention. So this is a giant step, starting from what we have discussed in 2018. At that time, we discussed about creating or building the global network for global dementia prevention. And now in China, our government has already kicked off the action plan. So that gives us a lot of support to promote dementia prevention and also dementia care. Among the 4 major tasks, cognitive screening is one of the major 4 tasks. And this definitely raised a huge demand for a cultural appropriate cognitive assessment instrument. But we understand that the under-recognition of dementia and cognitive impairment has been a great challenge in the society. In addition to the misconcept about dementia and cognitive impairment as a normal aging process, actually clinicians often encounter difficulties in distinguishing dementia or MCI from normal age-related cognitive changes, because in old age, some cognitive domains definitely will decline with age. So it's difficult to differentiate these different states. So we need an accurate or sensitive screening instrument, because this will be a great or critical step to support clinicians of researchers for early detection of dementia and cognitive impairment. We understand that currently there are different types of screening instruments, such as mini-mental status examination or MOCA. All these instruments have been translated and adapted in China, but we understand that their validity among Chinese adults actually have been affected by a lot of social and psychological factors. One of the top 3 factors include the population always lack of literacy in understanding the instruments. And also the test items sometimes are closely related to culture. So there might be some linguistic differences when we're interpreting test items. And also the overall lack of normative test data, so that limited the application of the instrument for the population-based study. So in this way, we need to find an instrument. So with the collaborative efforts between mainland China, Hong Kong, and Taiwan, Professor Helen Chu from the Chinese University of Hong Kong led the project, and we finally formulated the Hong Kong Brief Cognitive Test, abbreviated as Hong Kong HKBC. This instrument is trying to minimize the impact of education. It can tap into a couple of major cognitive domains. And also when we developed this instrument, we have taken a couple of special issues into consideration. So when we developed this instrument, we minimized the use of paper and pencil test. And also the clock drawing test has been modified, because writing the numbers or drawing the circle are very difficult for people who do not have much, who are illiterate. And also the naming of object has been modified, because we changed this. For example, in the MOCA test, the naming of the objects are not familiar for the population. But in Hong Kong HKBC, we use the familiar objects. So these objects are quite normally understood in the real life experience. According to our previous experience, the trail making test, subtraction test, and also the backward digital spans are very difficult. So the HKBC excluded this test. So this is the characteristics of HKBC. And it has been validated in Cantonese-speaking population when we first developed the instrument, and we found that it is very sensitive and specific for screening cognitive impairment So another study conducted in mainland China, Professor Zhang Nan from Tianjin led the first validation study to validate HKBC in Mandarin-speaking population. And we found that this instrument is very sensitive to distinguish AMCI and also mild Alzheimer's. And we can use different cutoff scores for identifying AMCI and mild AD. For example, when we differentiate AMCI from normal controls, the cutoff score can be set as the 23. And also when we differentiate AMCI from mild Alzheimer's, we can set the cutoff score as 17. And also when the study compared the performance of HKBC and MMSE, we can see clearly that HKBC performed much better than MMSE. So even when we see that the instrument is validated and sensitive, but it might not be appropriate for a population-based study, because usually when we set the screening threshold, they only help us to identify abnormal cases. But if we put this into population, there might be different factors influencing the performance of the individual in the population, like people living in the communities. So in this way, we consider that if we can build norms that can be used as mean and standard deviation from the representative population, it might help to facilitate tracking the longitudinal changes of a person's performance, especially for very early detection of cognitive impairment from the public health perspective. So that's why we developed a study to build the nationwide norms. Our the sample for the normative data for the HKBC total score was part of the national projects named as Chinese Neuropsychological Normative Project. And we have published the consensus statement of this project on the Journal of Global Health a couple of years. So after we recruited more than 2,000 subjects from who are cognitively normal, we identified that for the HKBC test, age and education still influence the performance. But we can establish a regression model, and use the regression model, we can build the converted HKBC score. That means HKBC T-score. And when the person got a score, raw score, we can reach a T-score, so that after we got a T-score, then we can compare the person person by person. So that's easier for us to interpret the results of the HKBC. Here on the slides, on the right column is a sample normative data for people aged 40 to 49. So when we publish the paper, we will provide the full picture of the normative data. Currently, the paper is still in submission. And using the HKBC T-score, we try to determine an optimal cutoff value for differentiated normal controls from the cognitive impairment subjects. And we found that when the cutoff value is set as 45, and we can reach very good sensitivity for early detection of cognitive impairment. But since this is only a screening instrument, the specificity is not quite optimal, but we can reach about AUC of 85%. That is acceptable. Now we have integrated the HKBC into our digital platform. So when the person use the digital platform here to screen the cognitive performance, we can provide the raw score, T-score, and also the percentile, so that it can be easily used in population in different communities. And now we are trying to educate more people, to train more people to use the instrument for their population-based survey, because the National Health Commission Action Plan is conducted in communities. So we hope that this instrument can be implemented more widely. And also we educate more memory clinics to use this instrument because they can track the longitudinal changes of the person's performance. That is much easier using the HKBC T-score. So this is our first step to build the national, the nationwide norms for HKBC. But actually in our Chinese norm project, we have identified 16 tests, neuropsychological tests. So in the coming years, we are going to publish more normative data about other tests. But
one more minute. We want to stick to the time because we are really very tight. Okay.
Sure. Yeah, and so the next step, we are going to explore the feasibility of HKBC among ethnic minorities. And we have to consider how we can implement this screening quite well. We still need to conduct implementation research. So this is my research work, and I hope that can enlighten more discussion in the coming session. Thank you very much, Maria.
Okay, excellent. You continue with your group, Ole.
Okay, thank you. So now I'm going to introduce my second presenter, Professor Ming Zhang from Sun Yat-sen University, the affiliated third hospital. Ming was our graduate student, but now he's a professor at Sun Yat-sen University. So welcome, Ming.
Thank you. Thank you for the introduction of Professor Hua Li. Can you see my screen?
Yes, quite well.
Oh, okay. Thank you, dear Maria, dear Professor Hua Li. It's very great honor to enjoy this from I'm Zhang Ming from the Department of Psychiatry, the third affiliate hospital of Sun Yat-sen University. Today, I will talk my research about the features of visual spatial function in dementia with Lewy body compared with Alzheimer's disease. Dementia with Lewy body is a degenerative disease, and it have a high incidence but often misdiagnosis as Alzheimer's disease and Parkinson's disease for some reasons. Discussing DLB from Alzheimer's disease is a very hard thing. We can use some scan, some examination such as PET and or PSG or MR scan, but it have some not very not very good part, such as the scan were expensive and it needs some a lot of time and need some person to accept in training. Because of for that reason, we want to find that instead there have some simple method to discussion DLB from Alzheimer's disease. In this disease, we should use the neuropsychological assessment. In the neuropsychological assessment include some domains such as visual spatial function, memory function, attention function, and exclude function. We are according as everybody knows, DLB have a visual hallucination, and it has a more visual spatial function defection. So we want to know that there are different from the memory and the language ability. Visual spatial function relies heavily on the integrity of the parietal lobe. Visual spatial ability tests may be more accurate than other cognitive assessment in discussing between AD and non-AD dementias. Some research suggests that a reduction in the number of angles may be.
Lynn booked us to go to Sealy Hall.
Oh, did you? Oh,
So we
excellent.
went to Sealy Hall.
I'm sorry. Maybe a marker of early DRB in the MSc subtest for.
Went swimming and stuff.
Oh, nice.
There's a big bed.
Oh, it is nice. It's beautiful.
In the morning. And then yesterday, because I had that much
Okay. Pardon. Should me going on?
Oh, yes.
Okay. And the different visual spatial function is generally defined as three domains, such as including visual spatial perception, visual spatial working memory, visual spatial construction. With the further research on visual spatial functions, and these domains are also regarded as indefensible. Some research find that the patients with DLB and Parkinson's disease dementia showed more service impairment in the visual pathways and dorsal pathways than patients with AD. And in a study by comparing compared to the control group and AD patients, the DLB group performs poorly in pigmentometer subtest, object decision subtest, and Kuber as organized subtest. In attention, impairment, motor skills, and executive dysfunction in DLB patients have been identified as a potential barrier to completing visual spatial structural tasks. But some studies have come to different conclusions. 10 analyzed 20 studies on joint clock test and find that in most of the studies there was no significant differences between the DLB and AD and VD, and a few small studies compared the performance of cognitive tasks such as visual recognition, visual recall, and vision attention, and find no significant difference between DLB, AD, and FTD. So, with the development of research, visual spatial cognition has been divided into different domains. Those controlled results may indicate that in the correct question is whether DLB is inferior to AD in all domains of visual spatial cognition, and does that help in the different diagnosis. So we want to compare the feathers of visual spatial functions in dementia with Lewy body and Alzheimer's. The subjects was diagnosed with dementia with Lewy bodies. We select from the Dementia Care and Research Center cohort of Peking University Institute of Mental Health from the January 2008 to December 2008, and all the DLB according to the grade tiers, and we select the AD, although the AD group and the normal group that has NC group. There was no significant difference in age, sex, and years of education in DLB group, AD group, and NC group. There were no significant difference in global cognition level from the MSE total score and the disease severity, and from the GDS score between the DLB group and the AD group. We use this research evolutionary tool, including general demographic information, including sex, age, years of education, resistance, and the evolution of the clinical symptoms such as CDR, NPI, GDS, such as and the assessment of the social function such as ADL, FAQ, and the global cognitive function, MSC and MOCA, and especially we use the have used the tools to mention the neuropsychological assessment of visual spatial functions from the four domains: visual spatial construction, including the Cuba copying test and the Gorka drawing test and the Patacon copying test and the vision spatial working memory of from the brief visual spatial memory test revised and the visual spatial attention from the trial making test A and the visual spatial exclusion function from the trial making test 1 and 2. The result is that we can see from the characters of the three groups, there was in the ADL score, the DRB group and AD group have no significant differences, but the score is higher than the NC group, and the FAQ score is the DLB is higher than AD group and higher than NC group. Now we can see the visual spatial cognitive function compared among the DLB, AD, NC from the every test we just mentioned. The CCT, and we can see from the CCT, DCT global score and the TMA and TMT 1 and 2, there are all have the differences from the TLB group and the AD group and the NC group. But we want to know, because we divide the visual spatial into the four dimensions, so we have to use this score to control every. We can make the every dimension only have one score. We can see through the z-score, we can see that compared to the AD, there are in the visual working memory and visual working memory and visual attention have the differences. To show the result clearly, we have a mapping, a radar map. In this map, we can see that the green is the DLB group, and the orange line is AD group, and the black line is NC group. We can see that in the visual spatial attention and the visual spatial construction, they have the differences between the two groups. So in the conclusion, we have in mind that dementia with Lewy body may present distinct fictions of visual spatial function from Alzheimer's disease. The function of the visual spatial structure and attention may be more impaired in dementia with Lewy body. This provides a theoretical bias for the further understanding the nature of the DLB disease. In the follow-up studies, samples and more targeted cognitive assessment tools can be developed to provide help for diagnosis and differential diagnosis. In addition, our team further explored the understanding imaging machines, which may be related to the different impairments in visual transduction pathways. Finally, we would like to thank the team, especially Professor Huali, for the guidance of this study. That's all. Thank you.
Thank you, Ming, for the excellent presentation. Now we are going to warmly welcome our next speaker, Professor Fengquan Zhang from the Beijing University of Post and Communications. Professor Zhang.
Okay,
Professor
I'm
Zhang?
here.
Yes.
Okay. Good morning, everyone. Professor Huali, Professor Morrow. I'm very glad to see you. Thank you for joining me today for this academic forum. My name is Zhang Fengquan, working in Beiyou University of Posters and Telecommunications. The title is VR-based eye tracking apparatus development and its applicability in earlier detection of BPSD. Now, the contents including the following main aspects. Part 1, background. There are high rates of BPSD in people over 85 years of age, and eye tracking technology can be used for earlier BPSD diagnosis in the immersive environments where patients inhibitors narrow behavior and psychological response, and be able to use the VR-based eye tracking to improve diagnosis. With VR in immersive environments, patients display nature's behavior and psychological reaction, enable research to improve diagnosis, use VR-based tracking. The analysis used eye movements pattern BPSD related samples can be identified earlier, which can help earlier intervention and treatments. Further, through VR personalizers, task can be further designers according to the needs and samples of patients, improving the accuracy and effectiveness of assessments. VR-based eye tracking provides a more natural interaction and behavior simulation that more realistically captures the eye movement patterns and behavior response of patients in the real world. Part 2, overview. Pupil center detection algorithm. An infrared light source illuminates the pupil generator reflection in the corners. An infrared camera captures this reflection and determines the corner of the pupil, deduces the rotation of the eyes, and meaning the direction of the gaze. There are many popular devices in the world, such as Pico, made in China, and Apple Visions Pro American, and Oculus Quest 3, 1, 2, 3, and so on. Tables of eye tracking technique in BPSD recognition and one, fixed points and attention. 2, cellular patterns. 3, pupil response. 4, vision search and tiger location. 5, vision perception and memory. Now it's part 3, eyes tracking algorithms. In this part, I will introduce some methods in the recent. One is the feature-based methods. Feature-based methods focus on detection specifics in image, such as pupil detection. Techniques such as image contrast enhance, image processing, including image enhancements, suppression of reflection less and other operation to improve the accuracy of pupil detection. 2. Methods based on mathematical models. Models-based methods aim to detect specific shapes in the images, such as different shape. They are methods often including image binarization and elephants fetus process. Shape fittings use geometric face techniques such as the LS method to imitate the space parts of eye. The third one, method machine learning and deep learning methods. They are methods use the machine learning and deep learning algorithms to process eye tracking data, often used to extract relevant eye features from image or direct estimate the screen local of the gaze water, such as CN and RN and other methods is used in the image recognition. For multimodal and eye tracking technology, multimodal emotion recognition by coming eye tracking data with other psychological signals such as EEG, height rate, and GSR. Users' emotion status can be identified and classified. Multi-model system, the integration of eye tracking with height rate monitoring and other feedback system enable real-time multi-model human computer interaction, integrating eye tracking with technology such as speech and gesture recognition, enhance the naturalized and intelligence of human computer interaction. The part 4, VR eye tracking ZPI. Since eye movement patterns can reflect trends in brain function and cognitive centers, researchers at this stage most use the eye tracking technology to detect BPSD related disorder such as AD, Alzheimer's disease, depression, and autism, and so on. The specified detection process of BPSD related disorders based on eye tracking technology, such as the types of disease, Alzheimer's disease, and depression and autism. The eye tracking signals, such as this distribution of attention point, we can test attention time and recognition the movement of the eye and so on. Alzheimer's patients use the eye tracking to find their wide in VR environment, such as we can see in the picture, the distribution of the calibration and validation points. Part 5, VR immersive therapy. With the continuous development of VR technology, research have further combine VR technology with eye tracking technology to detect BPSD related diseases. VR provides a more nature and immersive environment, and VR and virtual social scenes, daily activities, and so on. One, VR GP for autistic children. In immersive VR, distance adjustments of autistic children can be effectively supported in real time according to eye tracking technology. From the picture, we can image of the 5 interface for condition. Baseline and other images. 2, VR GP for AD patients. By assessing spatial navigation ability, it contributes to the earlier identification and understanding of spatial disorientation in AD patients. 3, VR therapy for social VR can treat social phobia behaviors and use eye tracking system to objectively assess symptoms in social phobia. We can control create different scenes to test the different people in the virtual environment.
Hi, Professor Zhang. I think that we only have 1 minute.
Okay. Part 6, application and characters research hotspots. The hotspots I will introduce some new methods such as earlier detection in Alzheimer's disease. Eyes tracking data can reflect the difference in performance on virtual text between AD patients and control, and how these different and socialized with cognitive delay, such as MLP method and SVM method can detect the different data for eye movement data. Part 7, future works. In the future works, we can six parts. One is combine VR with AR and mixed MR, VR, AR, MR to be used for AD's disease. 2, integrate eye tracking with other psychological science such as heart rate, electronic response. 3, develop more VR videos for rehabilitation training, as well as long-term tracking and evaluation system to continuously monitor patients' eyes movement data and BPSD. For different patients have great difference in their different VR environments. 5, when cognition eye movements signals is difficult for users wear glasses or people with different pupil due to eye surgeon to tracking eye movement and cannot calibrate the eye tracker. This work is now we are working here. 6, data collector by eye tracking and VR technology may have previous implications and need to be secured. Okay, that's all. Thank you.
Okay, thank you, Professor Zhang. Since we have run out of time, so I hope that our next a couple of speakers can make their presentation much briefer. So now our next speaker will be Lu Chun Wang. She will present on her work related to EEG.
Okay. Hello, Professor Wang. Hello, Professor Moro. Nice to see you again. And good afternoon, everyone. I'm Lu Chun Wang from Beijing Anding Hospital, Capital Medical University. I'm very glad to be here today to present my research about cerebral dominance representation of directed connectivity within and between left and right hemispheres and frontal posterior lobes in mild cognitive impairment. I will briefly introduce my research from the following aspects: background methods, results, discussion, and conclusion. Firstly, mild cognitive impairment has long been recognized as a transitional stage between normal aging and the onset of dementia. Existing evidence indicates that along this continuum, functional changes in the brain may precede both brain atrophy and the emergence of cognitive symptoms. Among various changes of brain function, brain connectivity stands out as a crucial indicator representing the dynamic changes of the neural communication across different regions of the brain. The connectivity within and between hemispheres or brain lobes may have implications for an individual's cognitive functions, including memory, language, and executive function. To our knowledge, the flow of information through cortical regions should be directed, such as in the transmissions between left and right hemispheres and frontal posterior regions, as demonstrated by the directed connectivity network. So in light of these considerations, our study primarily aims to investigate how cerebral dominance is represented in directed connectivity among MCI patients and to explore potential associations between cerebral dominance and cognitive performance. These are the inclusion and the exclusion criteria for MCI and healthy controls. We used several neuropsychological assessments to measure general cognitive function, memory, executive function, visuospatial function, attention, and language, and social cognition. We collected the resting state EEG data using a 5-minute period with closed eyes, and then we used frontal posterior displacement, that's DFP, and displacement between the left and right hemispheres, that's DLR, to measure frontal and posterior intralobe and left and right intrahemispheric dominances, and frontal and posterior influence, that's IFP, and the influence between the left and the right hemisphere, that's ILR, to measure frontal posterior interlobe and left and right interhemispheric dominances. Finally, 34 MCI patients and 23 healthy controls were included in our study. There were no significant group differences in age, sex, or educational level. MCI group showed poor performances in general cognitive function and 6 cognitive dominance like attention, memory, executive function, language, and visuospatial ability and their social cognition. These circle graphs presented patterns of the EEG propagation of the two groups in the 4 frequency bands. The direction of the EEG activity propagation is marked with the same color as the electrode where the source of the activity is located. After statistic calculation, we found that the DFP's value in the delta and theta frequency bands was smaller in the MCI group relative to the control group. The findings suggested that the frontal posterior intralobe rather than the left and right hemispheric dominance is compromised in MCI. The findings suggested that the information flow gathered more within the posterior of the brain than in the frontal part of the brain in MCI patients. The FP value in the delta and theta frequency bands was smaller in MCI group relative to the control group. The findings suggested that the information flow transferred from the posterior lobes to the frontal lobes was decreased than the opposite direction in MCI patients. In terms of the relationship between cerebral dominance and cognition function, among all the individuals, the DFP values positively correlated with the Z-score of the executive function in delta and alpha bands. The FP values in delta bands were positively correlated with the Z-score of the executive function, attention, and language. The ILR values were correlated with the Z-scores of attention in delta and theta bands. To be specific, we found the reduced connectivity dominance within the frontal posterior brain lobes, suggesting either a decreased information flow within the anterior brain regions or the increased information flow within the posterior brain regions. As we all know, the frontal cortex is one of the earliest regions to display pathology changes in MCI and AD patients. These changes include the accumulation of beta amyloid pellicules and tau tangles, which are hallmark features of AD. Thus, it can be inferred that directed connectivity in frontal areas may be disrupted to some extent in MCI patients. Also, we found decreasement in frontal posterior interlobe dominance in MCI patients, which indicates a reduction in transfer of information from the posterior to the frontal regions of the brain. The observation is consistent with the researches demonstrating long-range inter-regional functional connectivity in MCI patients, including a loss of directed information flow from the parietal to frontal areas across the theta, alpha, and beta frequency bands. We speculate that the trajectory of AD pathology spreading throughout the brain may also contribute to the compromised directed frontal and posterior connectivity we observed in our study. Furthermore, in our study, we also found positive correlationships between frontal posterior intro and interlobe dominance in the delta and alpha frequency bands and executive function. These observations support that the reduction of information flow within the frontal lobe may contribute to impaired executive function. Similarly, we observed a correlationship between frontal and posterior interlobe dominance and the performance in executive function, attention, and language. These findings not only strengthen the evidence for the role of information flow within the frontal lobe in modulating cognitive functions, but also suggest that the transfer of information between frontal and the posterior regions may contribute to the neural substrate of interbrain cognition that are crucial for maintaining
only 1 minute.
Okay, function. Sorry. Also, we found that some correlationship between frontal posterior interlobe dominance. The findings in our study suggested that the changes in brain functions within and between brain hemispheres or lobes in MCI are not only reflected in the alternations in the strength of brain connection, but also in the directional change in information flow. Directionality in information transmission emerges as a feature in age-related pathology conditions, offering promising electropathology markers for cognition decline. That's all. Thank you.
Okay, thank you, Lu Chun. Now we are going to move to next speaker, Zhang Ma. Zhang Ma is currently the PhD candidate in our group. Lu Chun, would you like to stop your share so that Zhang Ma can share his slides? Yeah.
Okay. Thank you, Professor Wang's introduction. All right, so wait. So the topic I'm steering is attenuated neural activity in processing decision-making feedback in uncertain conditions in MCI. I will cover 5 aspects and start with the introduction. MCI is a state that lies between normal aging and dementia, and perform poorly in decision-making, leading to inappropriate choices in daily activities. So studying MCS decision-making abilities is crucial. Decision-making can be divided into decision-making under risk and under ambiguity. The game of dice task and the IR gambling task are used to study those 2 types of decision-making in patients with neurodegenerative diseases. Behavioral study found that MCI perform poorly in both decision-making. However, it remains unclear whether MCI's poor performance is due to cognitive decline, such as memory and corrective functions, or dysfunction in the motivational system. Neuroimaging studies have also found abnormal activation in brain areas related to decision-making and motivational systems in MCI. However, due to its lower temporal resolution, neuroimaging is not as suitable as EEG for studying the dynamic neural activity features of feedback evaluation, which EEG technology can study from both time domain and time frequency. The EEG indicators related to feedback evaluation include 2 categories: ERP, that is event-related potentials. The main ERPs are reward positivity, IWP, and feedback P3. IWP mainly represents reward sensitivity. P3 represents attention, resources allocation, and working memory updating. And it is also related to motivational significance and behavioral adjustment. ERO mainly involve delta and theta activities, both of which reflect the excitatory and inhibitory process of brain neuron. Previous EEG study found that AD patients have decreased IWP amplitude, indicating the presence of compensatory mechanisms for declining executive functions. The lower P3 amplitude suggesting attention and memory deficits. Another study also found a decreased IWP amplitude in MCI, indicating monetary dysfunction during the pre-dementia phase. However, those studies either focus solely on early AD or do not address the P3, and both fail to consider ERO. So, our study aimed to explore the neural activity features related to feedback evaluation in MCI during the uncertain decision making. The main indicators we focus on are IWP, P3, the power of delta and theta, and task performance. Here is response times. And we assume that foster reward will modulate the EEG indicators. Second, due to potential abnormalities in reward processing system, reward effects in MCI would be diminished. Third, with the with declining cognitive abilities, MCI might experience reduced neural activity, leading to overall decreased ERP amplitude and ERO power. In the methods section, we automatically include 90 MCI and 20 healthy control participants. The inclusion and exclusion criteria are shown in the two tables. In decision-making tasks, both GDT and IGT, we encourage participants to maximize gains when while recording their EEG data. The recording, processing, and related statistical analysis of EEG data follow the process adopted by most EEG studies. In terms of results, MCI scored lower in MMSE and MoCA and took longer to make their choices in IGT. This display is the ERP results of GDT, while MCS, IWP, and P3 were significantly reduced, indicating that MCI has weakened neural activity related to feedback evaluation in risk decision making. Moreover, the feedback of death 25 and again induced large IWP and P3. The marginal interaction between group and amount for IWP suggests that the difference between dice 25 and dice 5 was significantly in healthy control group, but not in MCI group. Similar to the results of GDT, MCS, IWP, and P3 in IGT were also weakened, although the p-value for IWP is 0.07. In addition, cars with large numbers and loss feedback induced large IWP, and both IWP and P3 show significant interaction between reward and amount. In the ERO results, the main things that is that MCI group had overall reduced the dart power in both tasks, and the seat power didn't really differ between groups. Okay, in summary, our study found three key things. First, the ERP in MCI weakens during feedback evaluation. Second, their data activity weakens. And lastly, when faced with a complex IGT that took more time to decide. In fact, MCI might have a neural composition process foster. Despite the weakening of neural activity, MCI can still distinguish how much they get back and whether they win or lose. Previous studies have also found an increase in function connectivity in the front levels of MCI, which supports the existence of neural composition mechanisms. In addition, although MCI took more time to decide in the
only 1 minute.
Okay. In the complex IGT, they can still tell how much they get back and if they win or lose, which shows that the neural composition ability still work in complex decision making. In fact, in both GDT and IGT, the smaller IWP and P3 shows that MCI may have issues with their motivation system and corrective functions. The weakened IWP suggests that they are less sensitive to reward and loss, and the small P3 means dysfunction in attention, resources allocation, and motivational bias when processing decision-making feedback. The decreased data power also shows that MCS neural activity weakens. In fact, the striatum is one of the source of data activity, and the increased amyloid beta amyloid deposition in the striatum of MCI destroys the signal conduction of neural cells. So the weaker delta power might be related to increased beta amyloid deposition in striatum. Of course, much more research is needed to make up some of the shortcomings of this study. This slide presents some important references cited in this study. That concludes my sharing for today. This is a photo of our research team members. We're very grateful to Professor Wang and the team members for their help with research. Okay, that's all. Thank you all.
Okay, thank you, Zhang. Now we are going to move to Haifeng, Dr. Haifeng Zhang for his presentation. We are running very late, so Haifeng, please keep on time. Thank you very much.
Okay, thanks for the wonderful kind introduction of Professor Wang. Thanks for Professor Wang and Mario for this wonderful symposium. My name is Haifeng Zhang from Peking University Institute of Mental Health. Today, what I'm going to introduce is the effect of cognitive training on the brain function connectivity in mild cognitive impairment. As mentioned before, MCI is a group of older adults at risk for dementia. And the cognitive reserve theory and neuroplasticity theory makes the background for further study on improve the cognition of the older adults. And cognitive training is a repeat practice. It aims to improve the cognitive demands of MCI patients. And we did a meta-analysis on 2019 and 2019, and we found that it has a small to medium effect on the global cognition, and we found cognitive training could also improve the memory, working memory, and the executive function are not significant. And we further did a pilot study, and we found that after 12 weeks cognitive training, the trained MCI patients have an increased great matter in red angular gyrus and correlate with the memory performance. And we further did a study, and it is also MCI patients. We train the executive function and memory for 6 months. And one group received cognitive training while another group is a waitlist group. Our outcomes are neuropsychology tests and MRI. This is the training tasks which include memory and executive function. The memory including 3 tasks and the executive function including 5 tasks. This is the training interface on tablet. And this is the training sessions. We have 19 sessions, 4 times a week and 26 weeks. This is the elders was participating in our training. And this is the pilot analysis of the data. The baseline of the characteristics is comparable. And this is the change of the cognition. The arrows are towards the improvement. We can see after training, the intervention group have a better processing of speed and have a better subjective experience of their memory. And we also found that the efficacy was influenced by ApoE, and the ApoE4 else have better performance on working memory, while the non-ApoE4, ApoE2 participants have better on inhibition and shifting. And we further set red angular gyrus as the seed to see the connectivity of the brain. And we found that the change of the functional connectivity was seen on the brain, and mostly in the angular gyrus and the hippocampus parahippocampus, we can see the increased connectivity, while other brain, we can see the decreased connectivity. And the connectivity was correlated with the cognition. And also, I want to mention is that we are still ongoing other work very closely connected with the training and worked with Professor Wang. Now we are working on the national plan. What I am doing is to develop the intervention tool to WeChat mini program, and it is released in a very popular program named WeChat in China. Almost everybody use it. So it is free for the people, especially the remote elders who have very limited medical resources to free use it to improve their cognition. In summary, the underlying mechanism of CCT, which including cognitive reserve, plasticity, and what we found, the change of connectivity, and in the future, we still need large and longitudinal study and further to implore the effectiveness of cognitive training. This is my presentation. Thank you.
Thank you, Haifeng, for keeping time perfect. I think that my team have already presented 6 work, and I think that
Wally, for the sake of time, because we're just right on time, my suggestion is, why don't we complete the presentation and then we at the end have a general question and answer session? Would that be okay?
This is what I mean. So
okay.
I think that
because I have a lot of questions for your team, and I guess many people have questions, but I know some people will be running late. So then we go through the Edinburgh to the UK presentations now, and at the end we have a question and answer session, and those who can stay, we can have it for as long as we want. Is that okay?
Yes. So now
Brilliant.
I'm going to turn the chair to you so that you
Thank
can
you so
share
much, Wally.
Yeah.
Thank you so much for sharing this initial part of the symposium so well. Very interesting work, incredible. I got a lot of questions, as I said, but let's wait for the question and answer session. I will share my screen. Can you see my screen?
Yes.
Okay, so just I will start from where I left it in the introduction, just to mention that by the time we launched Glow DPP, we also had the Latin American and Caribbean Consortium of Dementia, two parallel initiatives that were aiming at very, very similar targets, characterizing what are the shared and unique aspects of underserved, underrepresented populations in terms of dementia diagnosis and care. So in this study, we interview experts from our region in Latin America, and it was very interesting to see what is that people were prioritizing in terms of research and clinical work as well. As you see here, the majority of people wanted to address risk factors for dementia. For example, compared to biomarkers for dementia at the time of this study, were at the top of the iceberg. Everybody wanted to have biomarker. In the community, people wanted to know more about drivers of dementia, and risk factors, especially modifiable risk factors and potential non-pharmacological intervention. That could be easily explained by a number of factors that I will share with you very briefly afterwards. You see, for example, clinical trials rated very lowly here, and it's that very few clinical trials running in developing countries for a number of reasons as well. So the community indicated that professional researchers tend to prioritize areas where they feel they can make a greater impact, but that also highlights areas where we have huge gaps to address in the community. For example, in this survey that we ran afterward to identify the status quo of biomarker for Alzheimer's disease in Latin America, gap and opportunities, we identified that neuroimaging biomarkers, especially MRI, are the most widely used. And we know that MRIs is useful to help in the identification of neurological changes, changes associated to dementia, but it's not in the pipeline of dementia biomarker because of a number of reasons. So then when you look at other type of biomarker, for example, peripheral biomarker like blood-based biomarker, eye tracking, or ocular-based biomarker, etc., and genetic biomarker, they were not as commonly used. But what is it? What we ask here is not just about the usage, but also the interest. So as you see, many people were not actually using this kind of biomarkers at the time we surveyed them, but they were interested because they have the infrastructure, they have the conditions, but they didn't have other things that I will share in the beginning. And there were a few people that were not interested in this at all. So, for example, when we look at different use, you see that in the neuroimaging, for example, area, many people obviously are using for clinical purposes, and some people are using CSF for clinical purposes. But when it came to peripheral and genetic biomarkers, so many people, the people that were using it, were using mainly for research purposes. So others were using it for both. But again, showing that neuroimaging biomarkers are the most widely used. So when we look at the uninterested people, the reason why they were uninterested is clearly it shows that it's not that they are not interested, it's just because they don't have the right infrastructure to really carry out this type of investigations. They don't have funding to really support the studies that can move forward the field or in the region, or they don't have knowledge. They don't have the training, the capacity in terms of knowledge to adopt these novel methodologies in the field. All in all, it shows that for regions like Latin America, and that's true for other countries, this study has been generalized in other areas like Africa, etc. We have seen that they share very similar landscape. So the lack of support, infrastructure, and funding precludes the possibility of adhering to the proposal made by, for example, the Alzheimer's Association, the National Institute of Aging, about the biomarker frameworks that we are expected to use. And in this satellite symposium from the Alzheimer's Association that we held in Mexico in 2023, a key outcome from that was that collaboration and harmonization efforts in Latin America, but in general, are essential to shape public health policies and foster scientific collaboration. Ongoing efforts in the region have emphasized the importance of inter-country support and the immense potential of international collaboration. I think that was one of the key highlights of that particular symposium, and which is quite in line with what we are doing here today. So then, when it comes to going more into cognitive assessment for dementia, particularly memory assessment for dementia, we have learned a bit about why some cognitive tests that have been traditionally used have not performed well. So most of the tests, memory assessments that are used or currently used to identify cognitive impairment in people at risk of dementia or in the earliest stages of dementia, focus on the function of the hippocampus. And now we know that the hippocampus is affected by Alzheimer's disease quite late. So there is a period here of time that corresponds to the preclinical stages of Alzheimer's disease, during which the pathology is accumulating in areas of the brain in the anterior medial temporal lobe network, like, for example, the entorhinal, perirhinal cortexes. And we have now developed assessment tools that can identify the function of these areas of the brain. So meaning that we have now the possibility to explore, using memory tests, the preclinical stages of Alzheimer's disease. These memory tests are known as context-free, as opposed to context-rich that are hippocampal dependent tests. These are, for example, associative memory. The context-free, they don't require the hippocampus, and they are based mainly on recognition. For example, one of these tasks is the short-term memory binding task that was recommended by the Joint Program for the Neurodegenerative Diseases, the working group in Europe. They suggested the visual working memory binding task. They also suggested the free and cue selective reminding task. But the visual short-term memory binding task is context-free. It's a recognition task that requires people to remember shapes, remember colors, or remember combination of shape and colors, and then decide if there was a change in the screen that follows. For instance, it's a change detection task. So people need to say, yes, these are the same or different shapes, or people need to say, these are the same or different colors, or these are the same or different combination. So the key condition here is the binding condition, because it's the ability to integrate this color shape in memory, the one that we have proved to be very sensitive to Alzheimer's disease. So we now have evidence that you see that even when patients with Alzheimer's disease can process shapes, can process color relatively well, their ability to process the integration or binding between color and shape is dramatically affected. And now we have shown that this is regardless of the disease variant. This is in sporadic late onset Alzheimer's disease. This is in familial early onset Alzheimer's disease. And we have seen not just in patients with dementia, but in asymptomatic carriers of the mutation that leads to Alzheimer's disease, very similar type of impairments. So now we have, relevant to the discussion we are having today, we have subjected this assessment to the cross-cultural validation aspect. And we have shown one of the members of GLOW DPP, Professor Monica Jesuda, used the test in Brazil, and she showed that this test wasn't sensitive to the level of education of people in Sao Paulo. Other colleagues in Colombia have used the test to explore whether people from different socioeconomic status, broadening the scope of sociocultural implication, not just focusing on education, but socioeconomic status, they also show that it's not sensitive to that. And later on today, Clara Kalia will tell us a little bit about the work we have done in ethnic minority groups in Scotland. So we have shown that this is a transcultural cognitive marker for Alzheimer's disease. And in this graph, you see that regardless of people, backgrounds, cultural nationalities, we constantly see these specific binding problems in this particular population. In line with the presentation so far, we launched the EuroLab EEG. This is a network that brings together people using EEG for dementia around the world. And I will be very happy to share the link later on so that people can learn what we are doing to incorporate EEG-based tool to the assessment of people with dementia, very similar to the work that has been presented so far. But we have also been using eye tracking to try to merge this cognitive marker with potential affordable biomarkers that can provide evidence about biological underpinnings of these cognitive problems in very early stages of Alzheimer's disease. So then I will finalize here just to mention that dementia is a global challenge, so therefore we need global solution. And we need to continue working in the harmonization of these strategies, exploring options that alternative assessments, type of new developments, whether technologies that can help us tackle these massive gaps that we are observing that are precluding actually the development of the implementation of these global strategies to fight dementia. And thank you very much for your attention, and I will stop here. And I will invite, as I said, we will have time for discussion at the end, and I will invite Clara Kalia, our next speaker, that will talk about visual short-term memory binding in ethnic minorities in Scotland. Clara, please.
Thank you, Mario. Can you see the slides?
Yeah, it's not in presentation mode, but if you go to presentation mode, that would be very
okay. It should be now in presentation mode, right?
Yeah, perfect.
Thank you. So thanks for everybody for attending this meeting today, and lovely to see you again, Professor Wali. It's been like a few years, like since we met in person. So hopefully in the future there will be other occasion that we can meet in person, because these kind of meetings are very fruitful, and so it's a pleasure being here again. So as Mario said, today I'm going to quickly share with you like one of the studies that I've been doing here in the UK using the visual short-term memory binding test with ethnic minorities. This is the link to our paper in case any of you is interested to read the paper and understand this more. As Mario said, I'm Dr. Clara Kalia and I'm a senior lecturer in clinical psychology here at the University of Edinburgh. And my interest is in cross-cultural neuropsychology. And the main reason is because we know, just to give you like a bit of background, that the number of migrants is increasing exponentially. And we have now more or less 281 million of people, like living in a country that is not their country. Like even just Mario and I, like we are living in the UK, but we come from different background. As you can guess from my accent, I'm Italian. Why this is important? Because also the number of older international migrants is increasing exponentially. As you can see, these are data in millions. And we also know that dementia is largely underdiagnosed among migrants, and some migrants are at risk to develop dementia. But what's the main problem with these numbers is that when we perform a neuropsychological assessment or cognitive assessment, language is the gateway to diagnosis and disease monitoring, and many migrants are not fluent with the language of the host country. And this is where one of the problems arises in neuropsychology, because assessing cognition in a person's native language with the appropriate tools and norms is a major challenge and a urgent need of sustainable solution. So together with another speaker today, Tam, that is going to talk after me, we wrote with other colleagues a paper on how to work with interpreter in neuropsychological assessment. It's a very detailed, like paper, and you can find the link to the paper here in this slide. Basically the picture that I show you come from this paper, where even how the arrangement in terms of seating is very important when you use an interpreter. But what's the main problem with the interpreter? First of all, they are costly and are not always available. They often need a long time before and after the neuropsychological assessment. Most of the time, they lack expertise in using cognitive assessment tools. Patients may not be as easy. So access to varies widely between countries. Even here in the UK, there is a huge access to interpreters. Most of the time is the only interpreter for the entire community. So this raises a lot of ethical challenges. And most neuropsychological instruments have not been developed and validated for interpreter-mediated assessment. Other additional challenges are the lack of knowledge of the patient's culture, so there could be like miscommunication. Cognitive tests are not customized to the language spoken by migrants, and neuropsychological assessment is based on Western behavioral assumptions and values, and aging migrants are often underrepresented in health and social care service. So this is where ethics play a huge crucial role when we talk about cross-cultural study, and in this case in neuropsychology, because it's very important that we use appropriate measure that has been validated and translated and adapted to the specific culture, use the right language. And like one of the things that are very important, local to me, is to develop training for the future generation of clinician and researcher working in this area. And so some of the strategies that's been developed to overcome these challenges are developing cross-cultural validated tests, but also develop tests with a limited involvement of interpreters. Among the other potential strategies, we create like a consortium in Europe. As Mario mentioned, the one developed in Latin America, we developed something similar in Europe, and it's called ICRON. And again, together with Tom and other colleagues, we wrote this position statement, and here you can find the detail of the paper. And basically, it's a collaboration from all that involve clinician, researcher, professors to students. It's very inclusive. We discuss how we can tackle cross-cultural neuropsychological assessment challenges here. And just to give you an idea, we also developed several tests to use in this context. These are just some examples. They cover from screening tests to neuropsychological battery or some other specific in memory and language or executive functions. But today I'm going to share with you one of the studies that I've been doing here in the UK with one core essential element, which is like the lack of use of interpreters, to understand like if it's possible to run an assessment without the involvement of an interpreter, because again, as I said before, they are costly, they are not always available, and can also add so many different kind of variables when we conduct an assessment. So we investigated if whether 4 cognitive tests used to screen dementia reveal any bias associated to participant ethnicity. We also checked the effect of education, acculturation, and language proficiency. The test that has been selected has been the cross-linguistic naming test, which is a language proficiency test, which include 40 English words, including 6 semantic categories. We also use the mini Adebra cognitive examination, which is a screening test for dementia, is the abbreviation of ACE, that has been used globally in every kind of research, that has been translated in different kind of languages. But this is not a cross-cultural test, so has been validated and translated, but there is not a theory behind cross-cultural neuropsychology, which is the crucial difference with RUDAS, with the Roland Universal Dementia Assessment Scale, which is a screening instrument for dementia developed for ethnically diverse population and is less influenced by educational and cultural factors such as mini mental state examination. And then, of course, we use the visual short-term memory binding test using 2 conditions of 32 trials. So one is the symbol shape condition, where participants were presented with either or 2 or 3 black shapes, are similar for the binding condition, with 2 or 3 shapes were presented each in different colors. So as you can see, this is a slide about the demographic, and you can easily see that there were no significant difference in age, education, and gender, and identified between groups, and the statistical difference for here in the UK and percentage of years the UK and English proficiency basically confirm the appropriateness of the sample recruited to test the hypothesis investigated. As you can see, there are 2 groups. One is the ethnic majority, so English-speaking, population, and then ethnic minorities, mainly from South Asian background. But also among the neuropsychological tests, the CLNT and the mini ACE and the RUDAS reveal significant difference across group, while the visual short-term memory binding test, particularly the coastal binding. So what we done, we run a 3-way mixed ANOVA for the visual short-term memory binding test with a significant effect groups. Both the effect conditions were significant. We also then run a regression analysis to explore the potential underpinning of the social cultural sensitivity shown by the neuropsychological screening test. So we run this regression model. So as you can see, ethnicity was a significant predictor of the cross-linguistic naming test. The MAS, which is the acculturation scale, so was a good predictor of performance of the MACE, which is the ACE shorter version. While education, years and percentage of years in the UK has been a predictor of RUDAS. However, neither ethnicity or other sociocultural factor yielded models that significantly predicted the cost of binding. So what we basically discovered that while ethnic minorities significantly differ from members of the ethnic majority groups in traditional neuropsychological tasks, their performance of visual short-term memory binding tests was comparable to the ethnic majority group, even without interpreters involved. Older adults from ethnic minorities showed no impact of their sociocultural background on the visual short-term memory binding test, However, other tests proved to be sensitive to the investigated sociocultural factor. So this is very important, when we talk about visual short-term memory binding tests, because it's proved to be insensitive to the individual ethnicity. It seems that to be language independent because so this means that a high level of English is not required. And so we can administer the test without even the interpreters. This is mainly because also the task relies on simple instruction, easy to understand and follow by people with little formal education and assessed in a language that are not proficient. It's also not affected by prior knowledge and experience. So we know this is a very crucial important point also to say the neuropsychological assessment must abandon that one-size-fits-for-all notion when it comes to dementia risk detection among ethnic minorities groups. So thanks for listening, and of course, if you have any question, this is my email address about the study. Thanks, Mario.
Thank you very much. Thank you, Clara. Excellent presentation. Thank you very much. Now I will introduce Tamlin Watermeyer from Northumbria University that will be sharing with us some work she has been leading on Down syndrome. Tam, please. You're on mute. Okay.
Well, great. Thank you very much, everyone. I'm just making sure that that is working. So yes, I don't have much time, and luckily Mario and Clara have covered much about the details of the particular task that we're interested in. So I'm really just going to stick to those sort of more recent findings, particularly where we're sort of, particularly because of Mario's work in this area, gaining a lot of evidence that this might be a tool that is very sensitive to indexing Alzheimer's disease processes, in particular areas of the brain that we believe are the earliest onsites of the disease. And then also, as you've just heard, Clara has provided some evidence that it seems to be insensitive to sociocultural factors. So really the question is this the ideal task? And when we think about developing these novel measures to assess the sort of diversity of populations, we're really looking for those tasks that are specific to Alzheimer's disease, targeted to the cognitive impairments associated with it, and insensitive to healthy aging, cultural background and literacy levels, which have all been sort of demonstrated by this body of work, mostly driven by Mario. Also, it's relatively quick to administer. So our thinking in the BIND group, the Binding and Neuropsychiatric Disorders group, which comprises myself, Joe Butler, Sam Danzo, and Mario, is can this be something that could be digitized in order to proliferate its use across different types of populations? And so during the pandemic, we decided to create a digital version and then validate this. It was very difficult because we went into lockdown, out of lockdown in the UK, but so it took a lot longer than planned, but we did achieve around 40 middle-aged and older age adults through a crossover design of people performing it at home and then coming into the clinics to do the same task or vice versa. And just briefly, no surprise, we found that there were no performance differences between these individuals when performed on our digital tool as well as an in-clinic lab assessment. So this gave us sort of the credence to be able to use this in an online digital situation. This was also self-administered when it was at home as well. What we're really interested, there's many different measures and indices that can be derived from the visual short-term memory binding task, but we are particularly interested in the binding cost score, which I think Mario briefly touched on, but just to remind everyone, is kind of taking into account the experimental condition as well as the control condition of only the shapes divided by that control condition and multiplied by 100 to derive a score. In Mario's previous work and with others, they have found that a score of over 20% seems to be highly indicative of Alzheimer's disease or the risk for developing it. In fact, it achieved in the same version of the task that we used an ORC of around 97%, with patients with mild Alzheimer's disease performing at 23% and above, and healthy controls only around the 2.9%. So with that in use, we over the pandemic, had access to a digital cohort that we built with around about 370, 400 participants. And using that bind cost measure, we divided them into weak binders. Again, that's if the score was around the 20%, and strong binders. This is a relatively young cohort, given that it's digital, but we did have a variation in ages from about 18 up to the 60s. And there's just some evidence with regards to some education and our gender values. What was interesting working with, this is something that Joe, Sam Olebole, a fantastic student that helped us with this, as well as Sam Denzo, led on the analysis, applying machine algorithm and training models to the data, and you can see a clear sort of bimodal distribution. But what was really interesting is the predictors of performance that we found with our analyses, where some very common risk factors, even this young, relatively young sample, seem to be driving whether someone is grouped into being a weak or strong binder. Most notably mental health, BMI, and fatigue, as well as subjective cognitive deficits. Obviously, this needs to have more validation in larger and more diverse samples, and also with older adults, but we are finding some common risk factors that we know are associated in the general literature already emerging in our relatively young digital cohort. Also, just to let you know that it doesn't stop there. We already have a Swahili version of the digital VSTMB, and we will be piloting this soon in Kenya through one of the cohorts that I'm involved in based there. So hopefully, maybe if we do this again, we'll have some data to report on that to see how it performs in the indigenous population and their local language. So I wanted to also spend some time to also talk about other avenues for inclusive assessment. One of my areas of research where I'm applying this tool is in people with Down syndrome. And why? Why is this important? Well, we know that the dementia prevalence rates in this population are often higher, and typically individuals with Down syndrome show an earlier onset of Alzheimer's disease. At the same time, they still receive inequitable access to dementia research, and this has a corresponding effect on their care. And one of the reasons for that is this real lack in innovation in neuropsychological assessment. We just do not have cognitive tools that have been designed for them in mind, and that can strategically stratify participants, for example, to take part in clinical trials. So it's really a crucial area of research that needs to be better positioned so that they can take part in the brain health revolution like everyone else in the general dementia space. So what I'm doing is I'm running a community-based project where I'm just recruiting 40 adults with Down syndrome and their carers and relatives. They are going through a number of different neuropsychological tests, not just the visual short-term memory binding task, but this is the main measure that we're trying to assess, first of all, whether people with Down syndrome can perform this task, and then again, how more broadly they perform in relation to other neuropsychological measures, as well as some biological measures. So we are piloting the use of a saliva device, given that imaging as well as lumbar puncture is particularly difficult to obtain in this population. I'm working with a collaborator who's a neuroendocrinologist who is a big proponent of saliva biomarkers. So we will be able to have an opportunity to assess also, hopefully, performance in relation to biological markers too. Participants so far, we have recruited 16. Again, I'm recruiting anyone over the age of 18. So this might seem quite young, but given that there is a strong indication that MCI sort of emerges around the ages of even as early as 25 in this age group, I really think the younger, the better. But we do have quite a nice broad early to midlife range. And a nice spread of men and women. And then, of course, IQ is also very important to include when assessing these participants, given the intellectual dysfunction. So once again, just to remind you, I'm only going to show results so far of some information we found around the binding cost score. And anyone who achieves a score of about 20% and over, there might be an indication that there is Alzheimer's disease process at play. However, what this means in the context of Down syndrome, we do not know yet. But this is the results that we're getting so far. So about 1, 2, 3, 4, 5, 6 of our participants so far are showing a binding cost score above that 20% threshold. Where you see nothing, that just means that they have a binding cost score of 0 because they performed relatively the same across the 2 different experiments. When I look at other data such as age, IQ, gender, it doesn't seem to be telling us anything at this moment, but of course this is a very small sample. We will wait to see how they form more broadly in other neuropsychological tests as well. But basically, the takeaway home message is that conjunctive memory binding ability is accessible in people with Down syndrome. They can perform this task. There has been only 3 participants who just did have difficulty with performing the task. They just did not reach threshold of being satisfied that they understood the instructions. So need to go back. I'm taking very detailed qualitative notes as I'm going along, try and see how we can make it more adaptable for them. Also, yes, we can categorize people as weak binders in this population, but what does that mean in the context of Down syndrome? Given the background of intellectual dysfunction, we will need to do this in larger samples and hopefully also validate with some biological markers. So caution is required. We're still in the process of collecting this data, and much more data is needed to really understand this in the context of broader neuropsychological performance, as well as what caregivers are telling us in how someone's everyday functioning or functional outcomes they are performing. So that was a very brief, I think I went even more brief than the bill, a snapshot into what we're trying to achieve by expanding out not just to ethnic minorities, but also thinking about other populations that are at high risk for developing Alzheimer's disease, but are really being let down by the dementia community in terms of research and funding and applications just not being directed in their direction. So it's something that we really do want to overcome through the binding collaboration and think about neuropsychiatric disorders across the continuum.
Thank you so much, Dan. I think that was a fantastic overview of all the work that is going on, led by the BIND group. It's a collaboration between different universities in the UK and abroad, as you can see, which is expanding. Thank you so much. And continuing with the topic of diversity, we have next Lindsay Stewart, a PhD student from the University of Strathclyde, who has an interest in dementia in the autistic population, and she's investigating how to help people with autism to get a diagnosis of dementia when they are when they are affected by this disease. Please, Lindsay, you can share your slides and start when you're ready.
Thanks, Mario. Can you see my slides okay? Yeah, great.
Yes.
Okay, thanks, and thank you very much for inviting me to speak. This morning has been incredibly interesting, so it's great to be part of this. And yeah, as Mario said, continuing on the discussion around diversity of population and neglected groups in dementia research, autistic people in the autistic population are also a neglected group in the area of understanding dementia in terms of assessment, impact, and continuing impact on a person's life. So my background is in autism and autism research, and through that I've recognised the need for a greater understanding in this topic. So that is why my PhD is focusing on this. So I'm specifically looking at detection and assessment of dementia in the autistic population. This is my supervisory group, but I just wanted to highlight the external members, Spectrum Voices. So I'm really lucky to have a group of autistic people who run their own radio station and run their own forum, completely led by autistic people. They support me with the research, they sit on my steering group, and they are a big part of guiding the research that I'm doing. Right down to language, how we speak to people, the priorities for the research, ensuring that everything that we do is going to work for autistic people and meet their needs in different ways. So I'm very grateful to the members of Spectrum Voices for continuing to support the research and be active members of the group. So similarly to what Tam was talking about there with the Down syndrome population, we know that autistic people have been neglected in terms of dementia research. In the wider ageing research, they have also been neglected. There is still a huge lack of understanding of how ageing itself impacts autistic people, and then within that, how dementia impacts. So there's currently almost no research looking specifically at autism and dementia as co-occurring conditions. We know very little about the prevalence rates, we know very little about the risk factors, and we know very little about how the best ways to assess for dementia in that population. So we currently don't know how many autistic people have dementia, how many people living with dementia are autistic. We don't know if the autistic population is more, less, or equally at risk of dementia than the neurotypical population. And there's conflicting research, the very little research that does exist. Some suggests that autistic people are more at risk, some suggests that they're in some way protected and therefore less at risk. So that's one of the areas that this project is really interested in. Also looking at the risk factors. So we know the commonly understood risk factors for dementia in the typical population, but we don't know if they are the same risk factors for the autistic population. We don't know if autistic people are potentially have different risk factors, and we don't know if the typical risk factors are have the same level of impact. So for example, looking at social isolation, which we know is a risk factor for the typical population, we don't know the impacts of social isolation in terms of dementia risk for the autistic population, who we know are often more likely to be socially isolated than the typical population. So the research is hypothesizing that the way we currently detect dementia will be unsuitable for the autistic population and needs modifying, and that autistic people are potentially more likely to experience different risk factors for dementia than the non-autistic population. So thinking about the way that we detect dementia, then we know that autism impacts on cognitive functions in the brain. So autistic people's cognitive processes work differently to the neurotypical population. So then if we are looking at how we assess dementia and how we assess the cognitive parts of dementia in an autistic brain, there's questions over whether the differences in autistic cognition are going to impact the results of a dementia assessment. And that's one of the main points of this research is to look at. So the three main aims were characterising the problem. So as I said, we don't currently understand prevalence rates. So we're looking at prevalence rates of dementia amongst the autistic population in Scotland, looking at the risk factors for dementia in autistic people, and then finally formulating a potential customised dementia assessment package for this population. So the final aim of the project is to have a potential package that we can use to assess and detect dementia in the autistic population. So the different ways that we're doing that, we're using what literature there is. So there is a lot of literature available around the cognitive aspects of autism, and we know there's a lot of literature available around the cognitive aspects of dementia, so we'll talk about that. We're looking at data and accessing data to try and establish prevalence rates and risk factor rates. And we're also working with clinicians across Scotland to understand their understanding and levels of knowledge. So there's currently quite a low level of understanding of autism in the older population amongst clinicians in Scotland. So that level of knowledge will be really helpful in helping us understand how this population is supported and treated. We'll be using all of the evidence, the data from the literature, the data from lived experience, and the data from clinicians to produce the potential assessment toolkit, and we'll have a piloted toolkit available at the end of the research project, which will be co-produced with autistic people. So then, thinking specifically about the assessment and how we assess for dementia, this graphic here shows the different cognitive areas. So on this side, we have cognitive functions that are sensitive to autism. So we know there are specific cognitive functions that are more likely to be sensitive to autism, more likely to be impacted by autism. We also know there are cognitive functions that are more likely to be sensitive to dementia. Where the problem arises is if there is a cognitive function that is sensitive to both autism and dementia, then this is likely to lead to misassessment, misdiagnosis. Because if we are assessing that cognitive function on the basis of a neurotypical baseline and not taking into consideration the fact that it may already be at a different level due to the person being autistic, then we could potentially miss dementia, or we could potentially misdiagnose with dementia when actually the differences that we're seeing in that cognitive function could be due to autism rather than dementia. So the first part of this research project is looking to identify the cognitive functions that are only sensitive to dementia. So the ones that are only sensitive to autism are not useful for us because they won't give an indication of potential dementia. The ones that are sensitive to both are less useful because there is a risk of misdiagnosis. But the ones that we know are only sensitive to dementia are the ones that we're really interested in. Because if we're assessing for those cognitive functions and we notice decline, we notice impairments, we notice differences in those cognitive functions, and we know that those differences are not likely to be because the person is autistic, then we have a much stronger evidence base that those changes, those impairments, those challenges are due to dementia. So how we're doing that is using the literature that is available. I've developed a tool to help me work through the literature and to help me develop strong evidence to support which cognitive functions, which cognitive domains are going to be of most use in our assessment. So looking at the areas with small effect sizes for impact on autism. So if a cognitive function has a small effect size in the autistic population, we know that it's therefore likely that autism isn't a strong factor.
Lizzie, you got a couple of minutes, all right?
Yep, thank you. In impacting that outcome. So using the literature to identify that, the strength of evidence tool is just a way of making sure we have the strongest evidence possible to identify the cognitive function. So this is an example of how we are doing that. This has taken the cognitive function of memory, and using the literature and using the evidence tool, I'm highlighting here the areas in red are the domains of memory functioning that are most likely to be affected by autism. The areas in yellow are likely to be affected, and the areas in green are least likely to be affected. So it's really the areas in green that we're interested in because there's the strongest evidence to suggest that they are not impacted by autism. So there's a close-up version of that. So there's a high level of evidence to suggest that, for example, long-term verbal recognition is not impacted by autism. If we know that that is impacted by dementia, then that's a really strong evidence to suggest that that's something we should be testing for in our pilot toolkit. So we'll be using this tool to work through each of the cognitive functions that we know are impacted by dementia to identify for each of them what are our areas that are most promising and most likely to give us accurate results when we're assessing. And just to finish up, these are just some quotes to highlight the importance of this research. So these are quotes from clinicians and from autistic people. So I hadn't even considered autism beyond children. That's something I hear quite a lot from clinicians in older age, so highlights the importance. And then from autistic people, if this project can stop one autistic person ending up in the wrong care setting, then it's a win for me. So yeah, thank you very much.
Thank you so much, Lindsay. This is very insightful. I know this is an ongoing study, but it's such a needed one. So thank you for the updates, and we will have some questions for you later on. So now we are going to have some presentation from collaborators who are exploring the area of EEG. Next is Dr. Javier Escudero from the University of Edinburgh that will be sharing with us recent developments about the neuroimaging analysis in people with Alzheimer's disease, at risk of Alzheimer's disease. Javier, please.
Hello, thank you, Mario, for the invitation to take part in this wonderful workshop. So, as Mario said, my name is Javier Escudero. I'm reader in biomedical signal processing in the School of Engineering. And in the research group, we develop algorithms to analyze different types of physiological time series and physiological activity. We have been collaborating with Mario for a number of years, and what I would present in the next minutes is some recent results that we have when we have applied some recent algorithms to data coming from fMRI and DTI neuroimaging scans of people taking the visual short-term memory binding task. So in this collaboration, what we have tried to do is to use algorithms and data analysis techniques to try to understand better in which ways the brain activity of people with or without the early stages of Alzheimer's disease changes during this task, and try to develop in the end markers of the early stages of the disease. So I will start with some motivation for what we try to do with these algorithms and how they were motivated. I'll try to give a very high-level view of what the key concepts are. I will not go into technical details. You can go and check the papers for that. And then I will illustrate the application to this neuroimaging data set that I mentioned before. So in terms of motivation for the development of the algorithms that we are doing in the group, I would like to go back to this idea of complex systems. And in general, these are systems that are composed of many, many different elements that interact with each other. They have feedback loops, they communicate, and somehow they create something that is much more than the sum of the parts. They appear in many different situations in the nature, but for the purpose of our work, we are interested in looking at the brain like a complex system and basically trying to understand how different parts of the brain interact with each other. And for this, we are going to be looking at two key concepts: the connectivity between brain regions that has been referred to in previous talks, in a previous talk in this workshop, and some ideas coming from nonlinearity. So even in fMRI activity, we expect to see that as a result of the brain activity and as a result of the task, there will be some different dynamics of play, some different interactions, and we are going to use recent techniques that we have used we have developed in my group to try to understand this. So this is the motivation for where we are coming from, or how we are interacting with how we are analyzing the data. So then now I'll move to the key concepts that I'm going to use to analyze the data. And the first one is the idea of graphs or networks. So just so that we share a common understanding of this, by graphs, what I mean is just a network, a mathematical representation of different parts of a system that are connected through links or edges. So we can think of the railway network of the UK as an example of a graph, but we are very commonly using graphs to model brain connectivity, connections between different brain regions, whereas for example, here the brain region A will be connected directly to regions B, labeled as B. So what happens in this study is that we're fortunate to have a multimodal data set that has diffusion tensor imaging. So it has basically information about what brain regions are anatomically connected through fiber tracks, to which ones. So we are going to use the DTI to build a structural network that tell us the connections between brain regions, and we are going to have fMRI, and that is levels of activity signals that are assigned to each of the regions as well. And what we do is that we are going to be looking at specific patterns, nonlinear patterns that appear in the fMRI activity. And in particular, we are going to simplify the fMRI activity and looking for patterns that look like this. We are going to be working with these 6 different types of very simple patterns, where what we do is that we compare the activity at one brain region and compare the activity in the regions next to it and next to it in the network. So basically, we're looking at the activity of a given region and then the neighbors and the neighbors of the neighbors. And depending where the level of activity is higher or lower, then we assign one of these patterns, 1, 2, 3, or 3, 2, 1, or 3, 2, 3, 1, 2, etc. So basically, we are looking for which brain regions have more or less level of fMRI activity in comparison with the neighbors and the neighbors of the neighbors. So we are building on an algorithm that we developed in the group a couple of years ago. And for details, you can go to the publication there. And then we thought that this algorithm was particularly promising to characterize this kind of activity in fMRI and DTI. And in particular, we were interested in understanding in which brain regions the visual short-term memory binding task cause differences between healthy controls and people with MCI. So this was work done in collaboration between John Fabila, a recent postdoc in the group, and Avalon Campbell-Cousins, a current PhD student. So as I said, we have the MRI that gives us information on anatomy and function. The subjects are doing a version of a short-term memory binding task, and in this case, our sample size is quite limited, but we have healthy controls, people with early mild-cognitive impairment, and crucially, we have 6 people who had mild-cognitive impairment, but went on to develop Alzheimer's disease after 2 years. So we took this data. For details, you can check the paper that we published in a recent conference. And what was striking to see is that across healthy subjects, some brain regions were always characterized by the subjects having always the same pattern of activity. So basically here, what we show is that we codify each of the 6 patterns we can have by a different color. And if you notice, some brain regions have always or almost always in the healthy subjects the same pattern of activity. So it seems that this is very consistent when looking at the activity over the DTI connectivity network. Here you have the visual representation of what is going on. So basically, we codify brain regions according to the color of the pattern. And some regions are black, meaning that there's no dominant pattern in the controls. But for some of the brain regions, it's very clear that one pattern is dominant in the healthy volunteers. We then went on to see what are the patterns in the people with MCI. And here, basically, what the colors show is that if the color is blue, that brain region had the same pattern in MCI people and in people with in healthy controls. But in some brain regions, those shown here as red or brown, the pattern change. So basically, this allows us to pinpoint regions that during the visual short-term memory binding task change activity. And actually, we found that even if this is a cross-sectional study, there seems to be evidence of progression with the disease, because after statistical analysis, the number of regions that show differences between controls and MCIs increases. We found one region with strong statistical significance significant differences between the controls and the people with LMCI, but then moving to MCI, the number of regions that survive statistical significance increase. And when we go with and compare controls with MCI people who converted to AD, then the number of statistically significant regions then increases more. So even if this is a cross-sectional study, to us, this suggests that combining these data science algorithms with a visual short-term memory binding task, it's possible to achieve a granular characterization of what is going on in the brain, and we can find patterns that were not visible with other techniques. As I said, it seems that there are gradual changes going on with disease progression. And actually, some of the regions that have been pointed are related to some of the abnormalities in the progression of the disease. So we have plans to try to expand these sort of ideas to EEG, to analysis of EEG activity. And I would like to leave it there. Thank Mario for the continuous collaboration through these years. Thank the funders of this research and the members of the group who were part of the research team at the time that these results were computed earlier this year. So that's it from me. Thank you very much.
I'm on mute. I was saying that thank you very much. Really promising finding, and I think the next step could be potentially to explore these new methodological approaches in EEG data and see what happens there. But I can see that there is some very interesting novel insights about prediction. So the next and final speaker is Dr. Keith Smith from our own Strathclyde University. Keith is from Computer and Information Sciences and has been working on a EEG front. Keith, please feel free to share your slides and start your presentation.
Hi there. So is that visible? Okay, start presentation.
Yeah,
okay.
We can see that's fine.
Yeah, so so there's a link between me and Javier. Javier was my PhD supervisor, and so he's contributed to the development of what I'm about to present as well. So we're going to get a bit technical, so I know you've been sitting through presentations for 2 hours. I hope you don't mind. I won't go into too many details, but it's slightly more technical, obviously, than a lot of what we've seen. But basically, the background for the methods which have been developed started with graph signal processing, which is basically a framework for trying to translate the classical signal processing methods to the domain of networks. And this takes its approach in seeing an analogy between the eigenmatrix of a graph adjacency matrix and the Fourier transform for temporal signals. So the idea is that each eigenvector of the matrix is representing a different frequency of the graph topology. But when we were looking at this, we were struggling to find out how to interpret this kind of methodology for EEG. But there were some methods which we adopted which are a bit more interpretable. So we went along this path of looking at what's called the Dirichlet energy. And essentially, this is just a function of the smoothness of the signal over the graph. Right, so you've got each xi minus xj squared multiplied by the weight of the graph. And the insight here was that we can basically use a matrix of connectivity and then apply this kind of short temporal signal, that function to that connectivity, and analyze more precisely in a higher temporal resolution the connectivity which is happening in the EEG. So essentially, we're creating a graph from global temporal correlations. We are looking at specific scalp areas. In this case, we're just looking at EEG in terms of the frontal area or the occipital area, etc. And then we're applying this signal processing method to those areas. And we basically what we found is this kind of thing. So we're interested particularly in the frontal region and the occipital region. And we applied this to healthy young students, I think, essentially doing the shape versus binding tasks. And here we're seeing the differences between the shape versus binding in terms of the p-values. And so in the frontal, in the occipital region, we're seeing an effect after 100 milliseconds. And then this kind of seems to translate to the frontal region after 20 to 40 milliseconds. So that was interesting. But we wanted to kind of explore this and generalize the framework that we were using. And so that's what we went on to do next. And we developed this general framework, which we call graph variate signal analysis. And the main idea, again, is that basically you've got this graph of stable connectivity, and this is going to be used to filter out basically information which is deemed as not relevant. Okay, and not relevant means that they're not actually existing within this graph space. So, for example, we might see a high correlation here between these two time points, between these two signals. But actually, if we were to look at the overall connectivity of those two signals, you see there's actually very low correlation. And this is actually a spurious correlation. So these are, the way this was actually developed, but these are just randomly independent signals, right? But we can still get these spurious correlations if we're looking at very small time points. So this is a method which we're trying to use to get rid of those spurious correlations. And particularly, we consider an approach where the graph weights were defined by the multivariate signal itself. And in this case, we call this graph variate dynamic connectivity. So again, the main idea is we use long-term connectivity estimates to filter short-term connectivity to give more robust short-term connectivity estimates. And there's a good visualization of this. So we have some different, here's the signals, the original signals. If we look at graph weights between the signals, where we know that only signals 1 and 2 are correlated, it's very difficult to really distinguish between the correlations here. If we're to look at it in terms of instantaneous correlation, we also see the same. But then if we use this GVD approach, where we use the long-term connectivity information to filter that dynamic connectivity, we then can really emphasize the actual correlated information between the nodes 1 and 2. That was all well and good, but then we came across a hurdle when we were looking at applying this to EEG, where we realized that if we're using long-term connectivity, which is actually statistically different between groups, then essentially the analysis of the short-term connectivity using this method is going to be biased, right? So what we did what we've recently done with Roy, who's just starting his PhD next week at Strathclyde. So he developed this, he was working on this as a master's student. So to this end, we proposed this filter average short-term functional connectivity. And it's a fairly basic idea, but I think it's quite powerful. So we take the long-term connectivity for a task computed for each participant. We then average these over all of the participants. And so this average filter is now no longer biased. So it's the same for each person. And then we're going to use this as our filter for proceeding with the analysis of short-term connectivity. And when we applied this to EEG simulators with ERP versus non-ERP conditions, and we're controlling here noise, different levels of noise, and also the number of trials. If we don't use this filtering approach, we basically fail at all levels and all number of trials. If we use like a more baseline wavelet spectra approach, we're not using functional connectivity, but looking at the spectral information, then what we see is that it's good when there's no noise, basically. But then whenever we add noise, it fails again. But then if we use our fast functional connectivity method, we're really able to see even in extreme noise levels with a reasonable number of trials, we can still see the differences in the data. And this was at 20 samples for a window for the functional connectivity, but we can even reduce this down. So this was down to just a single sample, and we can still see those quite consistent. We can still see those differences. And then we applied this to EEG data which came from Mario, which was this visual short-term memory binding tasks in the familial group and the sporadic group. There are more details obviously in the paper. But the main thing we found is that we saw this kind of replicable effect in the P300 range for sporadic MCI and familial MCI undergoing the binding task in theta. So that's all for now, and thank you. This is if you want to contact Dom Roy about applying these methods, then there's details there.
Thank you so much, Keith, for sharing these very recent findings. Quite very appealing again. I think it's fantastic to see so much work going on in terms of unveiling the potential biological underpinnings of this cognitive ability using these various neuroscience methodologies. So then I will invite Wally. Wally, are you still around?
Yes.
Okay. I'm sure you will agree with me that this has been, well, been a bit of a rally because we had a lot of presentation in a relatively short period of time. But I think that was the idea. The idea was to provide a very quick overview of the work that is happening, each side and each group. And I'm delighted to see the level of overlap in terms of the different methodological approaches, different type of research equations and problems our groups are addressing, which is very much in line with the agenda we put together almost 6 years ago, when we started with these collaborations and joint efforts. We don't have much time officially based on the agenda, but we could expand for people who are available. We could expand a bit beyond the agenda because we are starting now the question and answer session, the final one. So then we will open the floor to the audience. So anyone who has a question for any of the speakers, please unmute yourself and feel free to ask. I have please come forward. We cannot hear you.
Hello, can you hear me now?
Yeah, that's good.
Okay, perfect. So just a question to Mario and like everyone else in general. So we've been doing some work recently on, a couple of questions actually. First, maybe this has been done already, but for example, the eye tracking thing is very interesting to me. Like, I believe combined with like dynamic EEG connectivity analysis, since eye tracking is through time as well, we could probably get some very good results. I don't know if it's been done already, but if the goal is non-invasive at home type of thing combined with like virtual reality, it could be really interesting. I think this could expand really well. And the second is, so we've been also doing some work with a group in Australia for like in obsessive compulsive disorder. So we've been tracking EEG signals before and after transcranial stimulation. So that's the work they're doing. So we are going to analyze the EEG changes. So the way I'm thinking of it is, okay, if we could find, for example, so with them, they don't really have an idea of what changes are happening in this OCD thing. They're kind of like experimenting with different ERP tasks, etc. But the thing is like, what we want to see is like, okay, before and after, it's non-invasive transcranial stimulation. Do we have changes? Can we kind of track the progression of this obsessive symptoms? Can we see disease progression? Can we see if it's improving? Because in psychiatry in general, there's a shift towards from psychiatric medication, whose mechanism of action is really very unknown, to these more specific methods. So thinking about this to the binding task and Alzheimer's in general, since we have a specific task already, we have the binding task. We know we have these new methods where we can analyze it through time. We know like, okay, we've seen results, for example, in hyperexcitability in these things in the theta delta bands, and we know specifically to a general idea where it's happening. What is the potential for like treatment of this using specific neuromodulation techniques, you know? Okay. And this would be interesting because we can actually target specifically now
Well, now, this is a memory test. I will see if I can manage to remember all the question. But I think I can provide some insight about the two, actually. Regarding the first one, we recently submitted the paper for the forthcoming Conference of Clinical Trial for Alzheimer's Disease, CTAS, where we combine eye tracking and EEG. The thing that in that study, the two type of data were not collected simultaneously, right? So we had the same people assess very similar during the same day or very proximately in time-wise, and we managed to look at correlation between eye tracking variables and EEG variables, and we found very interesting correlation between, for example, ERP activities in frontal region associated with saccadic eye movements. So, we see some sort of relationship between top-down control of these cognitive processes and eye movement patterns in people with mild cognitive impairments. So I think there is a great potential, and I am aware that there are now initiatives that are bringing the two together, because ideally it could be to collect the data synchronously so that we can really get the time series from eye tracking and EEG simultaneously and explore. But from our own preliminary work, I can tell you that there seems to be interesting associations between the EEG, and we only look at ERP analysis in that particular area, but key ERP like P3, the P300 component that Keith shared, significantly correlate with saccadic eye movements in people with mild cognitive impairments. So then regarding the latter one about neuromodulation and potential, for example, stimulation intervention in people, I cannot talk about OCD because I've not worked on that particular front, but we have used, for example, TDCS, transcranial direct current stimulation, hitting areas of the brain who are involved in the binding network, and we have seen a significant increase in binding capacity. For example, reduction in the binding cost in people, even in healthy people, if you divide them in strong and weak binders. So you see that by stimulating this part of the brain, especially the parietal cortex, the weak binders tend to increase their binding abilities, indicating that there is indeed potential for intervention via electrical stimulation that can improve neuromodulation. Okay.
Perfect.
So,
thank you.
Any other question?
Oh, no, that's it for now. Thank you.
Thank you. Okay. Tam, you had a question?
Sorry, not a question, just an apology. I only found out after my presentation that my slides were not being presented, so I really apologize for that. I will re-record the session and share that with Mario to share onto the group if you're interested in the digital cohort and the Down syndrome project that we are developing. So
that
sorry
about that.
No
worries. No worries. Your presentation was great and it came through very nicely. In fact, I enjoy it because we set up a slide sometime, but if you share the slide, that would be fantastic. Thank you.
I think I was asking a lot for people to imagine what a bimodal distribution looked like in the context of the studies I was presenting, but I'll send it nonetheless. So I do apologize.
Yeah, you called for our visual imagery a lot there, but I think we managed. Wally, please.
Yeah, I just said that, Tam, although you did not share your slides, but it was wonderful. So when you mentioned about digitalized technology used in the cognitive assessment, just would like to share that when I mentioned about the CN-NOM project, we actually make those tools digitalized. So I think that when we talk about cross-cultural comparison, probably that would be a next direction for us to continue the bi-directional conversation and to see whether we can collaborate, built on our previous conversations. Yeah, that was great.
Absolutely, that's a great idea. So then I got questions now from our colleagues from China. And this question could be potentially addressed by Wally and probably by Hyphen Zhang as well, because this question is about your experience. I saw in your presentation, in both presentations, how frequently you are relying on technologies like handheld devices, tablets, to assess older people. And I saw in Hyven presentation, I saw that this group of older people in that nice photo he showed performing cognitive tests like a group type of, I mean, individually, but like a group of people in a room doing the assessment. So then I wanted to ask about your experience and technology-driven assessment in this older population in China. How older people perceive this assessment, how they see technology interact. Are there any particular experiences you have drawn from the introduction to the actual implementation of technology-driven assessment that might be worth sharing with us?
Yeah, thank you, Maria, for your question. I think that Hyphen's project mostly work directly with the old adults. The application I mentioned is they focus on the service providers. So I leave this question to Hyphen.
Thanks, Maria, for your curious about our project. And as you know, our intervention is just one point of our whole program. And Professor Wang also have a very large cohort which use the digital technology to assessment the older adults about their cognition, BPSP, and activity of daily life, and also the other demands. So it is really what we are doing now, and we are now put a lot of work to put forward the technology, and also the technology which we used now was supported by the national plan, and Professor Wang now is the key leader of the academic of the research. I hope what I said could answer your question. Thank you, Professor Maria.
Yeah, thank you, Hyphen. Yeah, Maria, as Hyphen just mentioned, yeah, actually, we are also concerned about the involvement or engagement of old adults in digital technology application. So that's why we work with Professor Fengquan Zhang to see whether we can develop some instruments or tools that could be applicable in ecosystem, so that can be used in their real life, not just to ask them to join in cognitive tests. So this is what we are currently doing. Yeah.
That sounds fantastic. It's just like assessing cognitions in the wild, as we some call. So, yeah. So people really, which is I think is fantastic for ecological validity. But I'm really delighted to see that, because as you heard in many of the presentations from the UK, we are engaging in something that's called co-design and co-production. So involving people who are participants of our research and beneficiaries of the research in the process of developing and the research process itself. I think that's important in terms of creating a technology aware older population, because, for example, in the UK, we still see a lot of stigmas, biases to the use of technology. Also, older people, especially in the older population. I know it's changing rapidly because the reliance on technology is growing quickly. So, but we still see that it's not even across the board. As Clara mentioned, for example, some ethnic minority groups have very different reservations regarding the use of technology, and I will be asking questions to Clara later about that. Thank you so much, Wally and Hyphen, for this insightful comments. So then I go. Sorry, I have a lot of questions, but anybody else want to ask a question? All right, since that will be me, the evil guy today. So okay, let me go for it. So So then I got a question for Professor Sang about virtual reality. I think this is fantastic. It was a great presentation and to see the different methodological approaches you are developing. But you saw that in my presentation, we're also using eye tracking, and this has been a journey in terms of implementing eye tracking technologies and merging eye tracking technologies with cognitive assessment to obtain these peripheral biomarkers that they call peripheral biomarker for Alzheimer's disease. So then I remember in one of your slides, you presented different type of headsets. And I wanted to ask you about your experience using different type of headsets, for example, to collect eye tracking data. So can you share some thoughts about that?
Maria, Professor John is offline now because he has another meeting. But I'll help you to pass your question to him so that we can keep contact through email. Professor John is currently one of our close collaborators on the apparatus development. His research interest is on the like the equipment development using digital technology. So I'm sure that he has his his unique insights about this aspect.
Yeah. Ali, I will be asking you and the team for permission later, but it will be useful to share. I will be sharing all these videos and material, but probably to share the email address of the presenters as well, so that if anyone then have an interest in a collaboration or something like that, people can get in contact. Is that okay?
Yeah, of course. So that's actually what I intended to ask you, that we can put together of this email contacts, and then we can make this group to be
Let's discuss later how we can create the resource, a centralized resource that will have all this material presentation, but also contact details of people, so that we can, because there is expectation that hopefully there will be some collaboration. I mean, the collaboration will continue, but new collaboration will emerge from here on. So that would be fantastic. So then I got a question for Dr. Wang, the EEG presenter. Is he still around?
Yeah, she's around here.
So, and the question is that in your presentation, you frequently refer to compensatory changes. There is compensation happening in MCI, and then you are interpreting most of these electrophysiological discrepancy between healthy people and MCI as compensation. But what you are showing actually is that compared to control, MCI people are displaying as less recruitment, less activation, smaller responses and their brain. And when you look at the literature that talk about the compensation, what we normally tend to see is an over-recruitment, an over-expression of brain activity, whether in MRI or EEG. So I wanted to ask you, so the rationale behind that interpretation of compensation in light of reduction of activity in the clinical group relative to the control group.
Yes, yes, Lu Chun. So you asked about the question from Lu Chun, right?
Yes, I think so.
Yes. Yeah, Lu Chun, would you like to comment on your data interpretation? It's sure around.
But that question could also be addressed by Man Sang, because Man Sang also talk about ERPs. So then both talk about EEG. So then either could actually potentially pick up and provide some insights about that.
Yeah. Zhang Man, would you like to comment on your data? It's not here. Zhang Man, are you online? I guess he's not around.
It's not online.
Zhang Man is offline already.
Okay.
Maria.
So then,
I this question for them.
okay. So the key question. So this is important because in the EEG, well, in the community using neuroimaging, these central biomarkers, imaging biomarker, whether EEG or MRI, what we are observing is a shift in the in activation in the continuum of neuropathological processes, whereby we tend to see quite often increased expression of brain activity, whether increasing hyperconnectivity or hyper-recruitment, increase in the evoker responses, in a way that at the very, very beginning of the stage, it seems to compensate. Compensate means that by recruiting more, your behavior is better. That's what we understand by compensation. So then at some point in the disease process, this over-recruitment stops being compensatory, meaning that we see that even though people try to recruit more and more, performance is going down. So it's no longer compensatory recruitment. So and at some point, everything goes down the hill. So there seems to be a pattern there in the process, in the relationship between behavior and physiological responses of the brain, so that might potentially provide indication of transition points in the continuum of neuropathological events of Alzheimer's disease. So then, if you can pass this question to them, and maybe later we can share this pending question, that will be very useful. Okay?
Yeah, thank you very much. I think that these are very constructive comments for their work, using how to use and interpret EEG data, especially when they are trying to use different approaches to analyze the data. So that is very important. Thank you, Maria.
No problem. So, okay, Clara, I got a question for you. I think these are very fascinating results, especially considering the ever-growing increase in the diversity given migration movements that are now going up more than ever before. So then in terms of this culturally unbiased type of assessment, as you show, for example, in a group of in a community in an ethnic minority group residing in Scotland, you apply this particular methodology and you didn't see any difference, any discrepancy compared to other traditional neuropsychological assessment that are more biased by these factors. So then I wanted, in the context of Akron, is that the way that you call the network, Akron?
Ikron, yeah, it's fine.
Ikron. So because Ikron is an amazing opportunity to explore this idea widely and internationally. There are some studies that report that if you assess people from this minority group in their own countries, so they mean migrant versus non-migrant, okay, you see differences. So then I wonder, as part of the ACROM network, have there been any kind of project, ideas, attempt to explore this potential cognitive phenotype, cognitive changes in people who are at risk of dementia, but who still live in their country relative to those who migrate to different countries?
Okay, so the simple answer is no, but I would like to explore this a bit more. So thanks for your question, Mario, because as you said, this is a growing phenomenon. So like but it's also beautiful that we are mixing each other more and more. But this has like a huge implication from especially for dementia point of view, because we don't have clinician trained, we don't have test validated, and so there is a lot of work that needs to be done. So there are projects going on in ICRON, cross-culturally, but most of the projects are now still in early stages in terms of validating, tests, making sure that, the different groups are assessed with different characteristics. What was important, the study that we did here, was the lack of use of translators, because if you read the majority of studying cross-cultural neuropsychology, there is always a translator involved. We decided to try without the interpreter because we wanted to check in case we don't have an interpreter available, just because, worldwide. There are more than 6,800 languages. So it's impossible to translate and validate every test in all languages. So we tried that. It worked very well. So like the visual short-term memory binding test could be a good tool that to explore, for example, like in other, contexts where migration is so different. Also because the sample that we involved in the UK were mainly from Southeast Asia, because it's the higher number of minority present here, but we did involve other groups. So like future studies can involve other groups. For example, now we are, piloting as well with Palestinian refugees as well, to check if there are many difference between UK and Palestinian living in the UK or there. But this can be applied in different kind of European contexts, if we want to talk about Europe, but this is true in every different context, because the level of migration change across different countries. So
Absolutely.
yeah, thanks.
Tan, would you like to come in? And...
Sorry, it's Clara just tapped onto it, but what I was going to say is that yes, the group is much more focused around just validating tools so that they exist, but there is opportunity specifically to look at these refugee populations that some of the European collaborators are working with, and also, some of us are also tapped into some more global health-directed work. So I know what I'm trying to build between ECRON and some of the global health projects is developing sort of diasporic cohorts that can be comparable to indigenous populations living in, say, the global south. So there is that opportunity as well to be able to look at the sociocultural, social, cross-cultural, and even kind of lifetime stressful kind of component to it, stress aspects of the different status of diaspora immigrants, as well as the indigenous populations.
Absolutely, because I think I found it fascinating, this observation that this is work presented by the Diversity and Disparity Group of the Professional Interest Area of the Alzheimer's Association. So the Latinos in the population in the States is huge. So they managed to compare immigrants from Latin American to actual people living in Latin America in their own countries and match them for every single factor you could possibly match. And then when they compared the two groups, there were significant differences. So what are the challenges that immigrants need to face that might be equipping them with different potential capability, resources? Again, it's a fantastic area to explore, given the big movement of humankind across the globe at the moment. And that's something that might be telling us, giving some insight as to acculturation is a protective factor against dementia. What's going on in the brain? Are these people growing cognitive reserve differently so that they could cope with aging more effectively in the light of the other challenges they need to face given the migration movement? So again, I think this is a fascinating, this cross-cultural neuropsychology area is fascinating and very worthwhile. Wally, please.
Sorry.
Yeah, I just would like to comment on Clara's presentation. I think that the methodology she used could also be transferred to our study in underrepresented area. Although those people do not migrate to big cities, but they actually are experiencing like cultural conflicts, because currently like social media and other types of information has been disseminated using different channels. So they currently are experiencing like even cultural shock, even they live in remote areas. So that's why I would like to comment that when we are trying to work in remote area, hope that in the near future we can work with you. We can adopt a similar methodology that you used, and to help us to work for the groups that are currently working on the fields in remote area. Yeah, thank you, Clara. That was very interesting.
Absolutely.
Thanks, Wally. It's fantastic what you said, because of course, like we will more than happy to like pilot it in China. Here I supervise a lot of Chinese students, so like there is a very huge interest as well. So that would be fantastic. So like if you want to receive more information about how we run the study, like I can send you the paper, but also like we can discuss the details. And as you can see, we select very short battery tests because we want to make sure that we tackle something that was crucial for us. And as you said, the acculturation scale is one of the key elements to understand the impact or everything else. But also like we can check also the idea of using interpreter versus not interpreters, because the data that we found out with the visual short-term memory body test has been surprising. And so we are very pleased that these are initial data. Of course like this is a pilot study, so like the idea is to go ahead in increasing the study. So that will be fantastic. So thanks for
thank you very much.
Thank you so much. So then I got a question now for the colleagues who talk about the diversity in the context of assessment. And here we have Tang and Lindsay that they cover very interesting and novel topics. One about Down syndrome and autism, which I think these are a fascinating area. So my question here is very, very general. So what are the key challenges? What are the key challenges to provide assessment opportunities, reliable and valid solution for people who belong to this, who are members, of these particular diverse populations? Maybe, I don't know, Tang, Lindsay, who wants to start with this?
My answer is very quick because it's something that comes up routinely. The brain health aspect of dementia prevention in these populations, the concept of that is not very strong relative to other at-risk populations. I'm shocked how many times I'm approached by parents who have not had discussions with their care providers about dementia even being a risk for their child, or even when they get to sort of the age at which we would start to expect cognitive decline, knowledge about dementia and also brain health preservation is very low in these communities. So I would suggest that is the number one thing. And as a result, they are just not asked to take part in research because of the barriers with cognitive assessment not being designed for them or necessarily suitable. So there needs to be, I think, a revolution in that space before we get anywhere with being able to provide therapeutic options.
I think.
Yeah, and
Alice is here. I'm glad.
Yeah, so yeah, I've stayed. It's okay. I would totally echo this similar challenges in the autistic community. I think as well that one of the other challenges with the autistic population is there's a real fear amongst the population of interacting with researchers, and historically research probably hasn't treated autistic people particularly well, and so particularly older autistic people who've been through some of the historical periods of less positive research, and also older people who maybe haven't been diagnosed, so feel neglected anyway. There is a real fear of interacting with researchers, engaging with research. So that's been one of the main challenges, is kind of developing that safe ground and developing that trust and building those relationships to say that it's not about us doing to you anymore, it's about us working together. And plus, just the general lack of understanding around autism and aging in general, the autistic population we are seeing a much bigger autistic population in their 50s, 60s and 70s. And that comes with its own challenges as well, and the challenges of people being diagnosed versus people not being diagnosed. There's a huge population of undiagnosed older autistic people, so that in itself is
absolutely
a challenge.
And I was thinking, Lindsay, I was thinking during the presentation that the cross-cultural aspect is another one that we could potentially add a layer, an additional layer to the problem, isn't it? Because we talk about one of the areas we have discussed is the element of social isolation, interaction, connection. But if you look at, for example, colleagues from the East that are sharing the day with us today, and Western society. We have big differences in the way people interact, connect to each other. So to what extent these societal differences in terms of being more collectivist versus individualist society could play a role in the way autistic people develop risk factors for dementia in this particular context? Wally, that's something that we could potentially explore and have a chat about in terms of how the neurodiverse population, for example, in China, is being looked at from a dementia point of view.
I also had a question for Lindsay, if you're still around.
Yep, I'm still here. Yep.
Yeah, so it's just so one thing I'm interested in is there's this maybe some evidence that autistic folk have a increased risk of dementia, but I wonder whether there's anything looking at whether you know of anything in the literature that's looking at, say, the psychosocial mediation of that. So perhaps the stress from masking and stuff like that, which may mean rather than an inherent biological risk, may be modulated by neuroinflammation and stuff like that. I don't know if there's anything looking at that yet. If you know.
Not that I'm aware of, no, but it's a really valid point because we know that, you know, all neurodivergent people mask to different levels, and we know that neurodivergent people, autistic people, are much higher risk of anxiety, depression, other stress-related disorders, not because they're autistic, but because they're autistic in a neurotypical world, if you like. So no, I don't know, but I think it's a really interesting point. And it also ties in with the social side of things as well, around if social isolation is a risk, and what does social isolation actually mean to an autistic person? And you may have an autistic person who on the outside has a really active social life, but actually is that positive for them? And is that giving them the positive impact that for a neurotypical person it would be? So therefore, is that mitigating the risk or not?
Or is socializing online work for that population?
Exactly. Yeah.
Javier, can I ask you a good question before you leave?
Yeah, that's fine.
So very quick, and that one can be picked by you and Keith as well. And it's about, so one of the key aims we have in relying on EEG as an affordable, reliable methodology to explore the underpinnings of this cognitive ability is the possibility of developing prediction models, right? So then going forward, how you see these task-related EEG, because that's pretty much what the focus presented on, the work presented on today focused on, is how you see that moving forward? Javier, Keith, if you want to contribute to that question as well.
If I may, I think it's a very exciting prospect. The EEG has very, very big potential to be deployed at relatively large scale in the community. So, you know, that I think that's one of the key aspects of the EEG, that is something that you could take out into the community. It's more affordable than some other neuroimaging test. And it's something that now can be made into a relatively attractive form factor. So now you see, I think now there's a lot of interest from companies that are coming into this area, not only for dementia, but also for some other applications related to well-being, to mental health, stress, even epilepsy. So now I think that it's becoming possible to have devices that are nice to use at home. They are easy to apply. They are not cumbersome. You don't need to rely on gel. So I think that that's a key enabler that I think we should try to harness, and then bridging that trend about EEG devices with, you know, new multidisciplinary ideas about how to extract markers related to the task, and trying to understand what changes in the EEG. For example, when someone does this task, then I think it's a really appealing prospect to be able to develop a marker of risk, or perhaps something that could be used to monitor progression every now and then. I think it could be useful not only for this, but perhaps even for potential clinical trials. I guess one of the problems is that, you know, sometimes it's a bit difficult to understand what is going on in the brain. So I guess it could be an alternative marker that could complement, for example, some clinical, and that perhaps could be appealing to pharma companies, for example. So I think it's very appealing, and this could go in a couple of different directions. But yes, combining low density, affordable EEG montages in the community with these sort of algorithms, I think it has a lot of potential.
Thank you so much. Keith, would you like to add something to that? You happy with that?
I think Javier has much more experience and expertise with it, so he's really covered everything, I think, mostly. I suppose the other thing is like with functional connectivity, I mean, often prediction isn't necessarily the goal. It's more like trying to understand more about the processes as well, and you know, how do we make predictive models which are also interpretable in that sense be important.
Absolutely, and in fact, in the latest revision of the ATM framework, the biomarker framework for dementia, that this is the first time where we see the EEG being mentioned in the framework, and they encourage the EEG community to come forward to start exploring those EEG markers that are proving most promising, and they hint at that particular aspect, Keith, the mechanistic approach. So that we can, I think the EEG holds huge potential to help us understand the disease process. And then the more applied approach, as Javier mentioned, that will probably take a bit longer because we need to continue increasing our understanding about what the EEG is telling us, whether in resting state or in task-related activity. I think this has been, well, my view is has been an amazing a discussion today, great symposium. I see the commonality. We have been talking across the different sides of the world about the influence of diversity among the underrepresented population, virtual reality, eye tracking technologies, EEG, technology-driven assessment, brain imaging, and neuropsychological assessment in a variety of topics. And I'm pleased to see that both groups have something to say about these different areas, confirming the kind of rationale behind the decision with Professor Wally to come together and share the development from our groups. So then I think hopefully this will be a seed that will lead to future collaboration, future work. Some idea has already been shared, and we will be working together with Professor Wally to explore how we can enable this collaboration, how we can create a context that will support people to potentially expand their agendas in this cross-cultural context that we have discussed today. I don't know if Professor Wally wants to say some final words.
Thank you, Maria, for leading such wonderful discussion. I think that today we have excellent presentations. I echoed your response, and also I think that we can also learn this from the Zoom chat box. So everybody likes the presentations quite well because we share our unique insights into the cross-culture and the diversity of cognitive assessment using different technologies. So the interdisciplinary approaches have been widely used and extensively discussed in our sessions. And also I think that a couple of our presenters have mentioned about in the future, we need to also take like biomarkers into consideration and to validate what we have learned in the psychological aspect, but also how we can make use of the combination between bio and the psychosocial aspects for us to understand brain health and also for the future dementia prevention. So the session is great. And I think that it's not only the demonstration of our success in the past years, but also I think that it gave us a new start for the future collaboration. We have talked about a couple of new prompt up ideas that we can extend and try to foster our collaboration between two teams. So after the meeting, we would like to share the email address, and then we can have more discussion, either in the symposium format or other like email conversations. So that I hope that we can keep contact and to see how we can strengthen our collaboration in the coming years, not only between universities, but also between different societies, different teams.
Absolutely.
Yeah. So
Absolutely.
thank you very much for the excellent presentations. Claria, Tam, we have met many years ago, but I hope that we can see each other in person. I have discussed with Maria to see whether we can possibly to organize the in-person meeting in the coming year. Yeah, so looking forward to see you in person. Yes. So
more coming through shortly. So we'll keep this new community informed about the new developments. Thank you again, everyone, for joining this initiative, for supporting it, and hopefully we will see some outcomes emerging from this effort. Thank you very much, and enjoy the rest of your day wherever you are. Thank you.
Yeah, thank you very much. Yeah,
Bye,
great.
nice to meet you all.
Yeah.